Good evening, everyone, and Happy New Year. Welcome to the first conversation series of 2022. I am Lauren Gates, and welcome my special co-host, Dr. Hal Stewart of the prestigious Stewart Center, and our featured speaker on airway dentistry, Dr. Ben Miraglia. So welcome, gentlemen, and let's dive right in and bypass the formal introductions because we have a full hour, but we have so much to share and so much to talk about. So, Dr. Stewart, we are both thrilled to have this event and our shared audiences. So why don't you kick it off and tell us a bit about yourself and the Stewart Center and why we're here tonight collaborating with the Stewart Center, Airway Health Solutions, and Dr. Ben Miraglia.
Well, thank you, Lauren. I really appreciate it. Thank you and Ben for allowing me to co-host tonight. This is great. Just a brief history on where I came to this place in my practice and professionally. I've been practicing dentistry 32 years, and for the vast majority of that, I've been doing dentistry what I feel is the best way to do it: stabilize the jaw, make sure the periodontal health is there, create beautiful occlusion. I started doing this in composite about 20 years ago, and I never liked the idea of mowing down teeth. And about 10 years ago, I started with my good friend, Craig Harry, who's probably on tonight. If you are, Craig, hello. We started teaching this and, TMJ-centered dentistry. And the more that he and I both learned about airway and how it affects the teeth, the joint, and then learning that many airway issues are, or probably the majority of them are, from underdeveloped jaws. We took this knowledge that we had, kind of like if you grew up playing golf, but all you did was putt. You're really, really good at putting. And Craig and I are really, really good at putting. We know TMJ, we know occlusion like the back of our hands, but we finally came to the conclusion about 8 years ago, that's the last thing that we need to be looking at is the teeth. And so I started down the journey of airway, and Ben and my paths crossed, and he told me about his practice, and I'm just going, this is like a mirror image of what we're doing now and what we're striving to be, just that he's been doing it a lot longer. So I've been treating TMJ and occlusion for 25 years. But now that's the last thing that we do, is looking at the teeth, and we start with the airway. And I'll tell you, it's been an amazing experience. So I'm excited to be part of this. I'm always excited to learn from Ben. And so, the journey towards on the golf game, putting is the last thing you do. Probably won't talk about a lot of that because there's so many more, not more important, but important steps before that. And if you can get to these patients when they're 5, 6, 7, 8, 12 years old, you may never have to putt. You may put the ball in the cup from the fringe of the green with your, pitching wedge. So, right. That's what I love about this, is that we can take kids maybe and save them all these horrible issues that people suffer with, and they don't even realize that it all is related to the mouth.
Well, we're so happy to be here and raise awareness to more people, as many people as we can. But Dr. Miraglia, you've been practicing airway dentistry for 18 years now, before it was even coined airway dentistry. Like, there was no such thing as it, and you were doing it, right? So we really look forward to seeing, an overview of your work and how airway dentistry is basically inclusive of comprehensive and aesthetic dentistry. You want to just give us a little brief overview on what you'll be presenting tonight, and then we'll just dive right in.
Yeah, definitely. Thank you, Lauren. Thank you, Hal, and happy to be here. Certainly, yeah, like mine, this is going to be a wonderful evening. I have about a 30-minute presentation to share tonight. It's going to cover basically some beautiful anthropology research that shows us where do you get the underdeveloped jaws from. It's amazing how, when you know the foundation of what you're doing, you can attack the cause of the problem. And so that was, probably the biggest piece of education that affects me today is the anthropology research on how and where do you get malocclusion, underdeveloped jaws from, and then knowing that you have a big opportunity to develop the jaws. And so, like Hal was saying, it's not really about the teeth anymore. They come last. It doesn't mean we neglect them or don't see them or don't pay attention to them. You need a foundation first, and then you build your way to the teeth, and the teeth are last, but you do get to them. But it's about the foundation first and the teeth second. And you're going to see, after having a little bit of that intro to anthropology research and what we learned from anthropologists on malocclusion, we're going to look at 3 different cases. Now, they're all similar because they're all underdeveloped jaws. We're just going to look at 9 years old, 19 years old, and 40-something years old. And we're going to look at 3 people who have a long list of symptoms in the sleep disorder, breathing, and TMD category. And the TMD symptoms, include the migraine headaches and all kinds of jaw pain and struggles, but usually for years, if not decades. And then we'll work through before and after photos just to show what it looks like when you address the foundation first. And so at any age, you can grow the jaws. So we're going to show you the 9-year-old, the 19-year-old, and the 45-year-old. How do you grow the jaws first and then go ahead and address the teeth second, and what the outcome would be, not only in the aesthetic department, because of course your patient's going to have a priority. They want to see a nice smile. We get that. But when you introduce them to the other things that you have available to you and how you can help them be healthier as well, then it becomes a significantly different level of dentistry you're providing when you're giving someone a foundation first so they could have overall health, not just oral health, and then delivering the teeth second. They can smile and be, incredibly beautiful and gorgeous the way they should have been, because natural teeth where they belong look amazing, and you're going to see some of that coming up soon.
Great. So why don't you go ahead and share your screen? I'll give some housekeeping notes to the Stewart Center alumni. Welcome again, and you're invited to join us for an exclusive town hall immediately following this presentation. And I just want to remind you that we're going to end this presentation and then go to a separate link on the Zoom that you received in your email. So that's for the Stewart Center. And for everyone else, if you want to ask a question, please use the Q&A box on the bottom of the screen, and we will take questions after the presentation. We're going to let Dr. Moralia kind of run through this high level, high speed here so we can get the most information in a short period of time. And then we look forward to a robust Q&A session. And we just want to keep in mind that we're not going to be discussing any certain products this evening. So please refrain from mentioning any specific products, appliances along those lines. It's all going to be under general terms this evening. Okay, Dr. Moralia, take it away.
Terrific. My PowerPoint opened up on the slide. We have slide 1 here, Airway Dentistry Overview.
Yeah, I'll
Okay,
need to
good.
change that logo.
We need a logo. Okay.
I'll need to change it. I love our new logo. I'm so excited.
Oh yeah, that's true. That's true. The new one didn't get on. Okay, I got to switch that. All right. So no photos. We're trying to be HIPAA compliant with the patient's privacy, and so I'm going to show you, a couple of minors here, and we're going to be careful. Some of those photos are age 9 to 16 years old, and so please, no photographs. Don't duplicate any of this. Don't put it anywhere else. It's just for your viewing pleasure and education tonight. I don't have permission to hand it out or pass it out or put it anywhere other than tonight. And that just protects our children's privacy that are in the presentation. So we're going to review how we got here, because where we are today is that there's an overwhelming majority of children have sleep disorder breathing. And we use the word sleep disorder breathing until we have a diagnosis. So sleep disorder breathing is anything other than proper nasal breathing. And proper nasal breathing, if we wanted to describe it simply, we'd say it's silent and invisible. Silent and invisible nasal breathing is appropriate. Anything other than that is unhealthy. So we'll call it sleep disorder breathing for kids. In adults, we start talking about OSA because it's the hottest topic going, OSA, OSA, OSA. And there's a significant prevalence and incidence of childhood sleep disorder breathing and adult OSA. And there are reasons why we have this significant incidence of these things. And we're going to get into it. So when we think about the most common malocclusion, it becomes crowding. So when we're thinking about what we see on an everyday basis in teeth, we see a lot of crowded mouths. We don't see a lot of spacing. And so when you have two main categories, crowded versus spacing, you recognize that you're going to see a whole lot of crowded mouths. And by crowding, we're thinking about we have teeth that are crowded in a bad bite, our malocclusion word, and we don't have 32 of them because they didn't fit. And so very few people walk in with 32 teeth. And we're going to take a look at what the crowded malocclusion kind of looks like. So when we're talking about crowded teeth, because it is the first thing we see. It's not about the teeth, but it is the first thing we see. And we tend to look at teeth and say, oh, here we go, crowded, or a malocclusion. But really what we're talking about is the difference between improper and proper development. And so improper and proper development is highlighted right here on this screen. So on the left side of your screen, you're looking at improper development. You're looking at underdeveloped jaws. Now, underdeveloped jaw structure delivers crowded teeth, and underdeveloped jaw structure delivers malocclusion. So you have this on the left side of the screen, a really nice view of what an underdeveloped maxilla looks like. It is narrow, it is vaulted, it is V or omega shaped. That's not normal growth and development. On the right side of the screen, you're looking at proper growth and development. So that is the first, 28 teeth have landed where they belong. Then you've got a broad, wide arch with a shallow palate and a great occlusion. So the difference between the two is staggering, because not only is it a better bite, or our occlusion is really nice, the biggest problem here is that when the maxilla is underdeveloped, it affects the nasal chamber. And so that's where we're headed with this big difference between having improper growth and development versus proper growth and development. As we start to learn about improper arch form and improper arch width, basically we're talking about inadequate development. So underdevelopment of the maxilla and mandible lead to crowded teeth. So the underdeveloped maxilla causes crowding, but the underdeveloped maxilla has an adverse effect on the position of the mandible. So when we're thinking about the mandible, it's the free floating, it's the mover, and it can land. And there is a landing point. It's where the maxilla permits it to. So when we're thinking about the mandible, it's a victim. It's a victim of the maxilla. So the only time a mandible lands appropriately is if the patient has a fully developed maxilla. If the patient has a fully developed maxilla, then the mandible has an opportunity to land where it belongs. Any patient with an underdeveloped maxilla has a mandible that is closing in an improper position, even if the teeth show you a beautiful class 1 typodont model. It's not exactly about the teeth, it's about the jaw development and position. So the mandible can be trapped back, which is most of the time where it is. So the underdeveloped maxilla, that narrow maxilla, the adverse effect on the position of the mandible is typically a retruded or trapped mandible. The more narrow the maxilla is, the more trapped the mandible will be. And the more trapped the mandible will be, the further the domino effect on the musculature, the condyle, the discs, the fossa, the eminent, the whole entire mechanism becomes skewed or off. And at what point is it off that it produces symptoms? Well, we recognize that you can't even practice in a dental office without dealing with TMD on some level. It's not a rare thing. It's not like, once a year or twice a year we have a patient talking about TMD. It's practically every day. So almost on a daily basis, the general dental practice has to handle the TMD patient. You're either treating them or you're referring them. You're doing something for TMD. You can't just ignore it. So we've got this trapped mandible. Well, really the biggest question would be why? Why are the maxilla and mandible underdeveloped? And that's where it leads us right to anthropology. If you want the answer to why the maxilla and mandible are underdeveloped, we get it from anthropology research. Dr. Robert Corricini, he's the foremost leader in malocclusion anthropology research. And with almost 40 years of research, books and journals, fossil population studies, animal testing, twin studies, genetic studies, all of the stuff that goes into where do you get malocclusion from, we learn it from someone like Dr. Robert Corricini. There are a lot of anthropologists like this. He just happens to be at the top of the food chain for anthropology research related to malocclusion. So he writes this fabulous book, which is like a summary of all of his research, how anthropology informs the orthodontic diagnosis of malocclusion's causes. Malocclusion does have a cause, and we learn it from the anthropology community. What we learn from anthropologists is that prior to 400 years ago, there's little to no malocclusion in the human race. So when you go back 400 years or more, the skulls that you would unearth and measure and look at would have 32 teeth with fully developed jaws. So you have fully developed maxilla and mandible, which means you have uniformity, lack of variation, beautiful presentation of 32 teeth landing pretty much where we would see, no matter where you would unearth that skull, it doesn't matter what area around the planet it is. Then all of a sudden you see a rapid rise in it. So what happens is they do a lot of traveling and studying of isolated rural people, and they recognize that the most significant difference, and then prove that this is where we get it from, is the hard diet. So in cultures that are isolated or rural, where there is no Western or industrial influence, breastfeeding is followed by a hard diet. So when you have a hard diet after breastfeeding, your jaw musculature works harder and then causes the development of the jaws. In these cultures, there's little to no evidence of malocclusion, or it also turns out there's little to no evidence of inflammatory or degenerative diseases, which we know there are hundreds of those, if not thousands by now. There's little to no variation, no matter where you are on planet Earth. An isolated rural culture, a non-industrial, non-Western culture, will grow to have 32 teeth with fully developed jaws, beautiful presentation without variation, and the jaw structure and the tooth positioning is the same. No variation. Then they start to watch populations as they become exposed to Western cultures. They recognize that the one commonality is that a culture that was isolated and then all of a sudden has what they would call broken isolation. Well, the first thing that happens is trade for food trade. And once the food begins to be traded, the diet starts to soften. So you go from a natural hard diet to now a processed and preserved and prepared and a softer type of diet. So there's a gradual shift from a very hard, tough diet all the way to what we would call today an incredibly soft or mushy diet. And then, of course, baby food. So we start thinking about what happens next in the anthropology world. They do all kinds of hard, soft diet studies on different animal groups, always to show the same results. When a group of animals is separated into two parts, and one half gets its natural habitat diet, the other half gets the exact same food, but just pureed. So baby food or Gerber, basically mush, they grow differently. So the soft diet animals will have smaller body mass and less dense bone. The less dense bone is body wide. Every bone in the body is less dense, not just the jaw musculature. But then you end up with smaller, weaker oral musculature. And if you have an early soft diet that delivers smaller and weaker musculature, then you end up with a narrower maxilla, a smaller mandible, thinner alveolus, and smaller condyles. So now you've got an underdeveloped set of jaws thanks to the early soft diet delivering smaller, weaker musculature. So what we learn is that, well, now we know that the predominance of the jaw growth and development comes from muscle activity, appropriate muscle activity. So bone yields to muscle and form follows function. So with the early soft diet, we introduce the opportunity for an underdeveloped set of jaws, which leads to, of course, crowded malocclusions. Now, the prevalence is significant by the generation. What anthropologists recognize is that cultures who have no malocclusion, all of a sudden, in their first generation after exposure to prepared, processed, and preserved foods, the malocclusion rate is 50%. And then second generation, it goes to 70, and third, it jumps to 85. By the fourth generation, you're over 90%. So 4 generations, when you're thinking about isolated cultures, a generation is 20 years. So we're talking about a 20-year interval. And by 80 years, the malocclusion rate is at greater than 90%. So the biggest problem we have is that the children today in America are 7th generation post-industrial living. So we are 7 generations past the advent of an early soft diet. So now that we have this universal early soft diet, we have smaller and weaker oral musculature. We do not get the bone growth early. And the largest percentage of jaw growth occurs from 0 to 2, which is 54%. The second largest percentage of jaw growth occurs from 2 to 4 years old, with another 15 tacked on. So with the early soft diet, we lose the opportunity for the jaw growth and development, and then we start getting variation. So with children today, we would see probably a 99% malocclusion rate. And you can think for yourselves whether or not you have more than one child out of 100. And remember, you would have to have a child go through full permanent tooth eruption, 28 teeth land where they belong, typodont model without intervention, and then get to 18 and have their wisdom teeth erupt into function. So the standard for full growth and for normal and ideal growth and development is that 32 teeth erupt where they belong without intervention. So if you have 1 out of 100 children go through full 32 tooth eruption to perfection, you can say it's a 99% rate of malocclusion. So in my world, I don't get 1 out of 100. It's 1 out of several hundred. 1 out of several hundred children can go through 18 or 20 years old and have all 32 teeth go where they belong. It's a tiny miracle to see that. So we refer to it as a unicorn. So when you're thinking about this, you have a 99% or better rate of malocclusion in children today. And of course, when you have an underdeveloped set of jaws, if you don't address the foundation early, you will be an adult with underdeveloped jaws. Just because you had braces to straighten your teeth doesn't mean you had your jaws grown and developed. So chances are your wisdom teeth won't fit. Now that variation increases means, well, now you have class 1, 2, 3. Now you have a crossbite on the right side, crossbite on the left side, crossbite on both sides, anterior crossbite. You could have a deep bite. You could have an open bite. You could have all the different types of variable malocclusions that we see. And next thing you know, we see all these variations and we have fancy names for them, but really it's a soft tissue dysfunction cause leading to a variable malocclusion. So where are we going? Well, the book has an entire, kind of summary sentence, which is pretty impressive. And what we learned from, Dr. Porcini's work is that dietary consistency and toughness promote proper bone growth and proper permanent tooth eruption, bringing about ideal occlusion. When non-resistant processed foods become ubiquitous after industrialization and the erupting and possible coordination of teeth lose the critical pathfinder influence of vigorous masticatory pressures, malocclusion shows a rapid rise. So within 100 years, you have over 90% maloccluded. It doesn't matter what the culture is or where it was around the world. It happens exactly the same pathway. The early soft diet delivers the underdeveloped malocclusions. So now, what are the results? Is it really about the crowded teeth and the bad bite? I mean, that's a piece of the puzzle, of course. Those are things we're in the dental field. We have to address them too. But is that really the main problem, crowded teeth, bad bite? So the results of having an underdeveloped maxilla and mandible, we check our anatomy to see what's our real problem. Well, we have to think about the maxilla for a second and refresh our memory. The maxilla, colored in yellow here, represents basically the bone that holds the top teeth in, of course. But it turns out the roof of the mouth is also the floor of the nose. The maxilla is the floor of the nose, as well as it is the palate. Depends on which way you're looking at it. But the maxilla also makes up the lateral chambers of the nasal cavity. So when we make a little triangle like this and we call this our maxilla, all of a sudden, this chamber is the maxilla. It's the floor of the nose and the lateral walls. And if our maxilla is underdeveloped, well, then we get this. So narrow and vaulted go together. You can't have one without the other. So if you are narrow, you are vaulted. And all of a sudden, narrow and vaulted means a smaller space for the air to flow, because human beings are obligate nasal breathers. So if you're an obligate nasal breather, you are built to breathe through your nose and be healthy. And the moment you breathe through your mouth even a little bit, you're heading towards unhealthy. And then it gets worse. Of course, the more mouth breathing, the worse things get. So this nasal chamber is dependent upon how well the maxilla grows. This is just an anterior view. If we have an underdeveloped maxilla with the vault rising and the walls collapsing in, basically we have this decrease in space to breathe. But it doesn't end there, because as the vault rises, the septum in the center is going to deviate to one side. So there's a little septum in the middle, and as the vault rises and everything shrinks, that septum will go to one way. And we have fancy words for that, deviated septum. Well, now you know how you get one. The cause of a deviated septum is an underdeveloped maxilla. A narrow maxilla with a high vault causes the septum to go one way or the other. When you have a deviated septum, you have one bad nostril and one worse nostril. So pay attention to that one. When you have a deviated septum, you have one bad nostril and one worse nostril, because the entirety of the chamber is smaller and then the septum is on one side. So you've got a bad nostril and a worse nostril. A deviated septum does not mean that you have a good nostril and a bad nostril, because the entire chamber is collapsed in order to get to a deviated septum. But we also have to look at profile view to see some color over here to see what happens if we have a lack of forward growth, because in 3 dimensions, when we're growing, we're looking for wider and forward growth. But meanwhile, if we don't have wider and forward, well, we're narrow and back. If the maxilla is back or not forwardly growing, there will be less color back here. And these colors represent the nasopharynx, the oropharynx, and the laryngopharynx. A maxilla that is retruded or retrognathic or posterior positioned rather than having grown forward, there's less color here. So now we have less space in the nasopharynx to oropharynx. When it comes to the mandible, well, we have the undersized mandible because of the early soft diet. So the tongue has less room to begin with, but we also have the mandible closing into the maxilla. And we know that the overwhelming majority of bites are in the class 1 and 2 category. Only the class 3, the mandible is forward of the maxilla. So for all of the class 1s and 2s, basically the mandible is behind or trapped behind the maxilla, and the mandible, as the mandible goes, the tongue goes. So a mandible that is retruded has a tongue that is retruded. So in underdeveloped human beings where the maxilla is back, so is the mandible. In every class 1 and 2 adult we see that doesn't have a full complement of 32 teeth with full jaw growth and development, an underdeveloped maxilla means a mandible tracked back means less color in the blue to purple range, smaller oropharynx and laryngopharynx. So of course, we're interested in wider and forward growth, but what we recognize is that underdeveloped jaws deliver an airway compromise. So when we start thinking about the maxilla and mandible, if they don't grow to their full potential, which all of that growth is very early, we start out with a child that has a compromised airway. A child that has a compromised airway could only grow up to be an adult with a compromised airway. Nobody outgrows this later in life, so you do not spontaneously correct your jaw growth and development on your own. You need help to get there. We see a lot of kids. So this is an example, 2 10-year-olds. We're comparing, obviously, proper airway development versus improper or underdeveloped. On the left side of the screen, we have a child who is 10 years old, has a bite that's appropriate, has a nostril. We can find the nostril and we can see how the air goes in and then goes through the nasal cavity, the nasopharynx, the oropharynx, and the laryngopharynx. Now, that airflow goes through this size chamber. This size chamber on the left side of the screen is like a garden hose. That's a nice place for airflow. It's a wide open space. Well, that space is determined by how the jaws grow. If the jaws grow wider and forward, we have a bigger chamber for the air to flow. On the right side of the screen, we also have a 10-year-old. We have a 10-year-old who has not grown wider and forward, narrow and back. If the jaws don't grow forward, we get less space. So instead of having a garden hose, we have a coffee straw to breathe through. So on the right side of the screen, that child has symptoms that begin at age 2. And by age 6, we start medications. By the age of 10, the child's on 4 different medications every day to control the symptoms that are related to cannot breathe, cannot sleep, cannot function well. So unhealthy on the right side of the screen. Just as a side note, both of these kids have a class 1 bite. So fascinating that you can have a class 1 occlusion and be so underdeveloped that you're on 4 medications by the time you're 9 and you're struggling in every facet of life and you cannot sleep more than an hour and a half at a time. So class 1 doesn't really mean that much unless you have full jaw growth and development wider and forward. The teeth are not the issue, it's the foundation that is. Now, when we take a look at their faces, what's on the inside is on the outside. One child has grown wider and forward where the lips are well ahead of the eyes. When the lips are well ahead of the eyes, you have a jawline, you have a distinct head and neck, you have extension of the upper and lower jaw forward, you have excellent lip position, chin position, you've got all the credentials of normal human anatomy. On the right side of the screen, the jaw growth and development is not there. The lips are directly below the eyes. The lip, lower lip, upper lip straight down, lower lip behind the upper lip, chin behind the lower lip, and then the neck blends from the chin to the neck. We have a blending of these tissues. We don't even have a distinct head and neck anymore. Well, because of the lack of jaw growth and development, we know there's a tiny airway underneath here. We have lack of jaw growth and development. We have a sleep disorder breathing child until you have a full PSG to determine it's an OSA child. Meanwhile, it's all about the jaw growth and development. So when we think about a child that doesn't breathe through their nose silently and invisibly, you have a child with sleep disorder breathing. And when you have a child with sleep disorder breathing, they are well on their way to becoming an OSA adult. So the pathway to becoming an OSA adult is it begins somewhere. So you back up. How did you get to OSA? Before that, there might have been some upper airway resistance syndrome. Maybe there was some snoring at one point in life. Maybe you began mouth breathing early. Really, the first step to becoming an OSA patient is an early soft diet. As soon as you introduce an early soft diet to a population, the weaker musculature delivers underdeveloped jaws, and the underdeveloped jaws give you a compromised airway, and now your poor breathing begins. And when your poor breathing begins, it will escalate. It is a chronic deterioration to OSA. So there are kids who get to OSA, certainly, and then there are kids who are just doing a little bit of mouth breathing, and eventually they will become OSA. So over time, you can graduate to OSA if you're left untreated. But the decrease in nasal breathing is the big issue, because once you have an airflow resistance that builds through the nasal chamber, you begin to mouth breathe, and it begins early. It starts changing your biochemistry and physiology. It'll change your biochemistry and physiology during the day as well, but it's during sleep where you really have a significant difference. The difference at night is that with an altered biochemistry and physiology, because of a decrease in beautiful nasal breathing, you have sleep fragmentation occurring, and that sleep fragmentation is fancy for disrupting a reparative sleep cycle. And this is how you deliver a list of symptoms in an unhealthy child who could only grow up to be an unhealthy adult. So our goal is to obviously be treating the foundation first, followed by the teeth second. So now we start meeting patients. Let's walk through 3 different cases in 3 different age groups to show you what it means to attend to the foundation first and then the teeth second. So we meet this nice young boy at age 9, and here's how he looks. This is the picture of unhealthy, and this is a child who has underdeveloped jaws, a crowded malocclusion, and we have to attend to the foundation first and then follow it with the teeth second. But here we have someone who, just to keep all the proper perspective, while we're meeting him at 9, he's already had phase 1 ortho by a different specialist. So having come from a specialist and had, well over a year of treatment in the phase 1 category, you're looking at that picture has 2 different perspectives. One is that's my before picture, and it's somebody else's after phase 1. So with every photograph, I'll just remind you, it's a before photo as I'm meeting this child the first time, but it's also after a year plus of treatment in the phase 1 ortho category by a specialist in the community. Now, this child, when we meet them at age 9, after phase 1 treatment, wakes every night, can't sleep more than a couple hours, is bedwetting 5 nights out of 7, has night sweats, night terrors, snores and mouth breathes through the night, has trouble with the alphabet. Now, in our world, we have to do a fair amount of myofunctional therapy, and we do utilize our orofacial myofunctional therapists to collaboratively care for these kids. This child, when working with the myofunctional therapist and as they're reading and speaking, has trouble and cannot say the alphabet without 2 mistakes at minimum and 6 at maximum in just a 10 try. So in 10 attempts to say the alphabet, 2 mistakes to 6 mistakes is the range. He's struggling in school, has done the 3rd grade twice, and then was told in the most recent conference that he would probably have to do 5th grade twice because this isn't going well for him. And again, post phase 1 orthodontics. And the reason we keep bringing that up is because this is the outcome when you focus on the teeth only. If you have a tooth focused approach, you're going to have a lot of trouble with helping heal a child. All right, so this picture is the profile. Of course, we have the upper lip to the lower lip to the chin. Everything is recessed or back. The lips are below the eyes. We do not have wide or forward growth. This is what's underneath. And again, this is, of course, our cephalometric picture that we've taken after this child has had a phase 1 orthodontic regimen. We have a significant amount of overjet. Of course, we're looking at the airway now. So we're seeing this tiny little straw. This is the reason why this child has so much symptoms. So he's struggling to breathe, can't sleep through the night because there's no airflow through here. So the body wakes up, he readjusts, goes back to bed, an hour or 2, comes and wakes up again. So this is the struggle. Now that we see the airspace in here, we start thinking about that overjet. Yeah, sure, there's a lot of overjet, but this puts into perspective that both jaws have to go forward. There's no such thing as being class 2 and the upper jaw needs to be retracted. There's no such thing as being class 2 and the upper jaw is too far forward. This child needs a lot of forward movement if you want a garden hose back here. If you want to open up that airway, then the upper jaw's got to go forward. When you see a class 2, what you should be thinking is the upper jaw's got to go forward a little, the lower jaw's got to go forward a lot. That's the kind of perspective you're looking at if you're addressing the foundation appropriately. And then, of course, having the tube behind here. Last but not least, shouldn't this child be entitled to 32 teeth when they get to be an adult? They should have 32 teeth where they belong. Let's talk about where they're headed. So this is the photograph we take. Of course, you're going to see a V-shaped arch. So we're narrow. We've got a V-shaped arch in here. We know the overjet. Here it is. So you've got a little overjet to contend with. And then there's this. This is the V-shaped arch. This, again, is after well over a year of phase 1 orthodontics. And this is the result of paying attention to the teeth and trying to wrestle with the teeth when you're not attending to the foundation first. These are the kind of results we see all the time. And then, of course, we get this nice appliance. And I know formally in dentistry, it's called the lingual control arch. I refer to it as a jaw binding appliance because now you're locking a 9-year-old in this position, which, first of all, this is smaller than they should be. This is not where that child belongs at 9. They're undersized. And second of all, now you're taking away any little bit of growth they might have because that locks those 2 teeth at that distance, which is incredibly narrow and small. If you notice in the photographs, the little baby canines are missing. This is the camouflage technique of extracting the primary canine so the 4 incisors can line up. And really what it is a subtractive technique that almost always leads to 4 bicuspid extraction, which is exactly what his phase 2 is. This child was about to go through 4 bicuspid extractions. The lower bicuspids have to come out because there's no room, of course. The upper bicuspids have to come out to close the overjet. We need to bring him back. A subtractive or retractive type of case would deliver 24 teeth. This is the child that ends up with the jaws are so small. We have 24 teeth by the age of 12 or 13 or 14. And then, of course, the wisdom teeth are coming out after that. So we end up with that pathway. Meanwhile, luckily, we get to meet him. We go the other direction. 15 months later, after having expanders, a little bit of bracket and wire, all of a sudden we're here. So this child gets, of course, myofunctional therapy, Frenum revision. You go through expansion with brackets and wires, and you're going to get expansion in both arches. So with nice fixed expanders, you can grow the foundation. You can start to get your breathing back, nasal hygiene techniques. You can address tonsils and adenoids if they're an issue. In this case, the adenoids were an issue. They were removed at a young age, and then they had to be taken out again because they grow back. But meanwhile, now we're in a position where we've got the first, chunk of teeth in the right place. In just 15 months' time, we've developed both jaws because we use expanders in the upper and lower arch. Upper and lower expanders can open up the jaws so that you can accommodate all of the teeth. So here we are now at the point where we have 28 teeth where they belong in a class 1 bite. But now we've, at this point in 15 months, have lost all of the symptoms. The child has 0 symptoms at this point and is now thriving in every category, sleeps through the night, breathes normally. There's no bedwetting, there's no nightmares, there's no night terrors. This child will tell you, I dream, I'm having dreams now, I can dream. Then, of course, we'll switch into clear aligners for phase 2 because we have a simple class 1 to do some final alignment. So we're getting a little older, we're a teenager, we get some alignment going with the clear aligners. Next thing you know, you've got a healthy child with fully aligned teeth. And by the time you get to age 17, because here he is in 2021, you can see the wisdom teeth erupting. So now you've got a 17-year-old who has the wisdom teeth erupting, and they will fully erupt into function. So you're going to have 32 teeth with a nasal breathing child that sleeps through the night without any symptoms, all from the age of 10 and a half, because we met them at 9 and addressed the foundation first. So from 10 and a half to now 17, you've got this beautiful class 1 bite with a full set of 32 teeth where they belong, and a child without any symptoms who's 100% healthy and thriving in school and in social settings. And then, of course, last but not least, you'll have your class 1 canine to molar for those who have to see it. Meanwhile, you remember the initial overjet. This is all accomplished without a single elastic. Nothing was pulled backwards. Nothing was pulled forwards. The growth and development process that takes place through expansion and growth and development appliances delivers both jaws wider and forward, and you end up having the upper, obviously going forward, but the lower more. And by the time you're done, you have someone who has a fully developed maxilla and mandible with 32 teeth where they belong and has a history now, a medical history that is completely clean. No symptoms, not one ever. Perfectly healthy child. That's a big change. This is a child that would have had 24 teeth and struggled for the rest of his life with his sleeping and breathing. And now you've got a kid who will never see the medical system because he breathes through his nose, and he will breathe through his nose for the remainder of his days, because once you have a garden hose and you have all that good jaw growth and development, it doesn't shrink back. Now we get to age 19. Let's take a look at an older teen, 19/adult. This is a patient who has some trouble because we're coming in with a malocclusion, but a history of TMD involving headaches. The migraines were weekly. It took her out of college. She couldn't survive with the weekly headaches. Sleep disorder breathing till you prove it's OSA or not. Meanwhile, we're going to get involved with removable upper expansion appliances. She'll need a lingual frenum revision. There'll be some clear aligner therapy. Basically, we're looking at the basics of growth and development. Foundation first, teeth second. And we learn the history, and at age 16, after finishing like 4 years in braces, the child ends up at the TMD office because she's got headaches and TMD problems. And this is what you look like when you're struggling. This is a 16-year-old that is absolutely struggling, and you can see all of the tension in the facial muscles. And here we have the head tilted, we have struggles, enough that, she's got TMD and headaches. And then we learn the full history that braces for 4 years, the TMD pain and headaches began during the ortho. The jaw clicking and popping starts. The braces are removed just prior to 15 years old. By 16, she's sent to a TMD specialist. And then, of course, whether it's orthotics or splints or however you might want to call appliances that a TMD specialist might make, can stabilize and reduce the symptoms of the patient, but then she's referred to us for orthodontics. So when the TMD specialist gets her kind of calmed down, at age 19, she comes in and we get to look at that. So remember, this is the result of 4 years in braces. So we've got 4 years in braces, and really what we have is an underdeveloped maxilla and a significantly underdeveloped maxilla. So what you're looking at here is the before and after. Now, the before is across the arch. I'm a big fan of the transverse measurement, the distance between the upper first molars. This 19-year-old has 27 millimeters between teeth 3 and 14. Now, 27 millimeters isn't good if you're 4 years old. A 4-year-old should be 30. So it's no surprise that you've got a significant history in headaches and TMD. When your maxilla is that small, your mandible's trapped in a bad place, nothing's going to be right. So 27 on the left side of the screen. On the right side, you're looking at 37. You're looking at a 10 millimeter expansion here. Now, the first 7 millimeters were removable adult expansion appliances. So we use removable adult expansion appliances to grow the bone first. You grow the bone, which is what you're looking at, bone growth first. Then I get the last 3 millimeters with clear aligners. So 7 plus 3 is 10. So we go from 27 to 37. And we do put a little bonding on the undersized laterals, because by the time we're done putting these teeth where they belong, the tooth size discrepancy in the lateral incisor would be significant. And of course, tooth number 10 is a little microdont, so you got to add a little extra bonding on that one. But meanwhile, when you develop the arch by 10 millimeters and you get to 37, which is reasonable, you have your lower uprighting and alignment taking place. And then you get a nice bite like this. Now, the only two teeth that have composite are 7 and 10, because they were too small. So 7 and 10 have composite. The rest are her own teeth with whitening gel, of course. So what you're looking at is bone growth and development first, followed by tooth alignment and coordination second. You have a fully upright set of teeth that has a perfect occlusion. And what happened to this patient is within a few weeks of starting the removable expansion appliances, the headaches were gone. So usually within the first few weeks, the headaches start to decrease, the TMD symptoms start to decrease. And by a few months in, you're basically done with your symptoms. And next thing you know, you're headache free. Well, now it's been 5 years. It's 5 years post-treatment. So what you look at on the left side of the screen is someone struggling and having, a significant, her most significant TMD symptom was the weekly migraine headaches. And so in her world, that was number one. The clicking, the popping, the other discomfort issues were minor convective headaches. On the right side of the screen, you're looking at someone who hasn't had a headache in years. Then, of course, you can see the difference in the smile. Of course, when your jaw is 27 wide on top, you're going to look like this: narrow, big, open buccal corridors. Then, of course, when your jaw is fully grown and your teeth are coordinated beautifully 10 millimeters wider, you can see all the way to the molars in a nice, easy smile. And you've got a patient who has a 5-year now track record without a single headache. Getting to 41, so 40 years old plus, you have a TMD patient here coming with, again, discomfort. We'll learn about his situation. But he comes in again. This is the look of someone who's struggling. You can see in the facial musculature, you can see it in the lips, you can see it in the, everything showing you here someone who is not doing well. And then, of course, we would learn, what are the symptoms. This gentleman here has his two biggest symptoms are that with the muscle achy and fatigue problem, as soon as he starts to chew, his muscles start to hurt. And in just a few bites time, he has to stop and wait and let it calm down to finish chewing. And it does the same thing when he's speaking. The moment he starts to speak, you can feel it coming on. And next thing you know, the muscles are fatigued, they tighten, they're in pain, and he has to slow down. So he cannot speak at will and he cannot chew at will without the discomfort happening in all the facial muscles. So we take a look at him and we, interestingly enough, you can notice there's 16 teeth in that arch, but he's really narrow. So he has an underdeveloped maxilla, his mandible's trapped back. He shows up with the horrific malocclusion of the underdeveloped variety, and we're going to open him up. So with the jaw growth and development followed by the tooth coordination, if you don't have any crowding and you have to develop a foundation and open up that upper arch, you're going to get some spacing. So we developed enough for a whole tooth here. So the premaxilla loves to grow forward. The posterior maxilla loves to grow wider. So you allow the body to do it as naturally as possible. So the posterior segment goes wider, the anterior segment goes forward, and then you can make anything you want there. You want to put 2 implants in, go right ahead. The implants weren't in the finances at this point, so we did the 2 bonded ceramic bridge work here. So you're looking at Maryland bridge work of the ceramic variety. They're bonded to the enamel. They're totally prepless. And this, again, is we're 5 years post-treatment, too. He's had these for 5 years. The lower upright, totally upright and wide. Now the tongue has more room, so now you can see the lingual alveolus in there. When you get to the end result, you have someone who started with an edge-to-edge bite and a horrible occlusion that he couldn't really feel his back teeth touching because the front teeth would crash. Then we went and developed that entire maxilla wider and forward, and we ended up with a normal overbite and overjet. So how is it that we opened up a whole chamber for those teeth and only ended up with a little bit of overbite and overjet? Any patient who has a narrow maxilla has a trapped mandible. The moment you start to open that maxilla up, the mandible will go forward. If we only widened his upper jaw, he would have presented full class 3 then. Because if you widen the upper jaw and you keep 8 and 9 right where they are, if you don't give him forward growth in the maxilla, he'll show up with a free mandible and be full class 3 with a negative overjet. We opened up enough chamber for a full beautiful tooth at the premolar, the extra premolar site. So if you recognize him having 32 teeth at the beginning, he has 34. This is an additive technique. Instead of taking out teeth to fit stuff into what's there, you grow the jaws, and if you didn't have crowding to unravel, you get extra teeth. An additive technique is in the growth department. A subtractive or retractive technique is going to take away tongue space and air breathing space. So we get this beautiful overbite and overjet after growing the jaws, and it makes a big difference in the patient's smile. Now, again, it's just whitening gel. The only 2 pieces of porcelain in his mouth are the extra premolar behind the 2 canines. All of the rest of the teeth are natural. So here you have the natural appearance of his smile going from this narrow jaw to this wide jaw. But meanwhile, what you're looking at is someone who has absolutely no muscle fatigue, no TMD symptoms, and now it's 5 years straight. So a 5-year track record now post-treatment without a single symptom at any given day, week, month, or year. You can talk to him about how comfortable he feels. He can talk forever. He can chew forever. He has no issues. So on the left side of the screen, fatigue, strain, struggle, probably 2 decades worth. On the right side of the screen, an absence of any TMD symptom for 5 straight years. You got someone who looks younger, looks healthier, is now 6 years older. Meanwhile, is basically living the happy, healthy life with a beautiful smile they can enjoy. So the patients are happy with a nice smile. But when you get rid of their headaches, you get rid of their TMD pain. And then last but not least, none of the patients that we treat end up in splints or orthotics or night guards or anything like that. There's no such thing as doing growth and development, jaw growth and development, followed by tooth alignment, and then landing in a night guard or any type of splint orthotic you might want to call. You're done with that forever because you've now addressed the cause of the problem, which was that underdeveloped maxilla to begin with. So we basically treat all of our TMD patients with maxillary growth and development because the maxilla is the criminal and the mandible is the victim. If you give yourself the full upper jaw growth and development and then coordinate the teeth to have a beautiful bite, everything can be where it belongs, meaning jaw, musculature, condyle, disc, all of it. And when you have all of it, you end up with someone who, like all the rest of them, just wears a clear aligner to bed. They have a clear aligner style retainer that they wear to bed every night, and it maintains the perfect tooth alignment. Because we know what happens when you don't wear your clear aligner to bed, your teeth can shift a little bit. But meanwhile, with that, he can wear them like every other patient we have gets a clear aligner retainer. They wear it for 2 years before switching to another one. A single clear aligner in any patient, whether they were a Bruxer or have a TMD problem, can be worn for 2 years without having a mark on it. And that's one of the nice features of having developed the jaws and knowing that the breathing is better is that there'll be less clenching and grinding to begin with. So you can lose all your symptoms. You can enjoy wearing a clear retainer to bed every night. And then, of course, last but not least, where was the profile at the beginning of this? I saved this for last just to show you what that edge-to-edge class 3 lack of lip seal and, of course, mouth breathing was doing to him. So you're in the sleep disorder breathing category until you have a full diagnosis of what the actual situation is. Now, with all of that maxillary growth and development, and then, of course, you have your wonderful overbite over jet. With the maxillary growth and development and the mandible following it, you end up with lip seal at rest. So now he has lip seal at rest and he's a nose breather. And that would be why he sleeps better and then breathes better. And of course, you have all of these things lined up because they're all comorbidities. When you're thinking about patients who, oh, this patient's an airway patient, or that patient's a TMD patient, or that patient's a crowded patient, they're all the same patient. So your patient has crowded malocclusion, underdeveloped jaws, chances are they have a sleep disorder breathing issue because it's very rare to find someone with crowded malocclusion but can be a nasal breather that's silent and invisible without resistance. And then, of course, the TMD symptoms are significant from childhood through adulthood. And don't forget to include headaches in that category. In fact, most of the time, we're not including the whole list of things that are TMD symptoms or related. So a larger percentage of our patients have TMD symptoms. We have to start counting the headaches in there too. So again, we threw that out there in rapid fashion. I know Lauren's going to jump back in here. I think we have Q&A coming next. We'll get a good discussion going over what you just saw.
Exactly. Well, if anyone can take all that information, let's see. Am I back feeding here?
Not now.
It's okay. Okay. Sorry, I don't want to hurt anybody's ears.
Oh, I think it is back.
It is back. Let me just see. Let me go on mute for a minute. Dr. Stewart, you want to take over and ask a couple questions? And
Yeah, sure. Can you hear me okay?
Yeah, totally fine.
Okay. Because we have 2 computers here. My computer that I'm on was about 8 slides behind, but your audio was brought up, so I was watching it on Adriana's computer. So I just want to make sure that I'm coming through.
Sure.
Ben, what a great general education in 30 minutes. Amazing. Couple of things I was thinking of. Could you address what effect ankylosing tongue tie has on jaw development?
Yes, absolutely. So yeah, you have 2 categories. The first one is the early soft diet. So the early soft diet is known to produce underdeveloped jaws thanks to the weaker and softer musculature. So with an early soft diet, you have a weaker musculature, so you don't get jaw growth and development. Now, when you're thinking about ankyloglossus, the tongue tie, having a tongue tie, if you have a frenum that is restrictive, restricted tongue mobility also results in underdeveloped jaws. And it turns out the more you measure and pay attention to whether or not there is a tongue tie, the more you recognize most people are restricted. So it's not a rare finding. It's an overwhelming majority. Now, if you're a child with a restricted tongue, you become an adult with a restricted tongue. You don't outgrow that. So I like to use protocols that are quantitative and can then be taught to a parent or patient that you have restricted tongue mobility. So abnormal shortness of the lingual frenum delivers restricted tongue movement. A restriction in tongue movement delivers a lack of jaw growth and development. So you can have underdeveloped jaws thanks to your restricted tongue mobility, but really where you get the majority or the biggest proportional difference in the jaw growth and development is the early soft diet. But of course, these two things are working together. We have the early soft diet. Whether someone even recognizes that the patient has a restricted tongue and addresses it is a whole nother thing. Any patient with a restricted tongue mobility should have a frenum release with myofunctional therapy. At any age, that would benefit. Whenever the tongue is restricted, it's held down, but the top part's held down. That means the back part goes backward. So a depressed or lowered or restricted tongue produces a posteriorly displaced tongue. So now all of a sudden, basically what happens is you have the restricted tongue mobility will give you a lack of jaw growth and development, but will also produce an airway restriction at the laryngopharynx. So it's something to include in the diagnostics, and it's something to teach the patient so that it's part of the treatment. And now that, I'm 29 years into dentistry, but I didn't even know about that until probably 12 years ago. So when you think about starting this 18 years ago and doing growth and development on children and adults and working my way, I was picking up pieces along the way. I didn't have it all locked down 18 years ago. So now you pick up that piece of the puzzle and you're like, oh my goodness, look at that. Then you learn, hey, I need frenum revisions and myofunctional therapy in most of the patients I see. Not a few patients, it's most.
How about sleep studies with children? When do you find it necessary to put a
almost
child
never.
in a study?
Almost never. And so for children, and again, to be clear, I'm not treating sleep and I'm not treating TMD. So what I'm treating is jaw growth and development. So when you think about sleep issues or TMD issues or malocclusion or crowded teeth, those are all symptoms. So I'm not treating any symptoms. If you're treating the jaw growth and development, so I'm a dentist, I'm a general dentist, my lane to stay in is diagnosing underdeveloped jaws, diagnosing malocclusion and treating malocclusion, but in the foundation first, teeth second. So when you're thinking about the sleep credentials, you can take and look at questionnaires to learn about sleep, and you can certainly get information to figure out, is there quality and quantity of sleep going on? But meanwhile, if you're not nasal breathing without resistance, meaning silent and invisible, you have a sleep disorder breathing issue. Whether or not you want to go for a sleep study, I don't think I send 1 or 2 children a year for a sleep study. And that's when you would have a combination of factors that you might need it. In other words, let's say that child has massive tonsils and adenoids and you have resistance from the pediatrician and the ENT. You may need a sleep study now to show this child is really struggling. And now we have a moderate obstructive sleep apnea child who we can do jaw growth and development on, but I can't take golf ball tonsils and shrink those. Golf ball tonsils that are touching, I can't get ahead of those. So while most kids aren't in that category, you can find a child where the tonsils and adenoids need to be removed. And sometimes having the sleep study goes to show and help the ENT and the pediatrician recognize the child needs more than just expansion and jaw growth and development. They're going to need tonsil adenoidectomy. In my world, that's a few kids a year. So if I'm seeing several hundred kids a year, 2 or 3 need the tonsils and adenoids out. Most of them, because they're in a category where the tonsils and adenoids are bigger, but they're not kissing or that big. So what happens is when you do deliver the jaw growth and development and you convert the child to a nose breather, the tonsils and adenoids shrink. So if you can get them to shrink, you win. You don't even have to take them out. So I'm not a fan of removing the tonsils and adenoids. Number one, even as a first choice, it's not even a solution anymore, because if you have underdeveloped jaws and a terrible airspace, you take out the tonsils and adenoids, you still have a terrible air chamber. It's still small. You took the contents out of a small tube. When you take the contents out of a small tube, guess what size the tube is? It's still small. Most kids who have their tonsils and adenoids out with underdeveloped jaws remain a mouth breather. And if you remain a mouth breather, your adenoids and or tonsils can grow back. So we see that it's quite common where they come in and they said, oh, they were taken out years ago. Guess what? They still remain back in a problem. They go back to the ENT. Some of those kids have to get them out twice. So we're not trying to take things out unless they're severe. And that's where a sleep study might come in handy. But for kids, yeah, I don't even know if it's 1 in 100. So it could be less than that. It's probably 1 in 200 kids we ask to get a sleep study. Adults, much more common. It's the opposite. The adults start talking about their sleeping and breathing. I'm like, yeah, that sounds terrible. You got to get a sleep study. We need to know the extent of it. So an adult who's further down the road of deterioration, it's probably a standard. Get the sleep study, get a CBCT showing the full airway imaging and the color and the area and the volume. Go to the ENT and get a nasal scope. Let the ENT put the scope in there and come back with a report. An adult, you're going to have a little bit more of the credentials of, the airspace going from that direction. Kids, not so much.
So yeah, well said. You're treating symptoms. You're treating the symptoms, not numbers.
Treating the cause.
And the cause, right?
Underdeveloped jaws. So treating the cause category, not the symptoms and or the numbers.
Yeah, I missaid that. You're basing your success of your treatment, treating the cause based upon the cessation of symptoms.
Well, when you have a human being with fully developed jaws, they don't have a breathing problem. They don't have symptoms. You basically have a healthy human being who doesn't need the medical system. And the moment you have underdeveloped jaws, welcome to the medical community. You're going to be a medical patient forever.
What about adults that you are expanding and growing their jaw that already have pretty severe deterioration of the TMJ? Do you find that those, I mean, of course they're going to improve. Do you find that the TMJ stabilize?
Healing, only healing. And so, the TMJ, whether you want to talk about the condyles or the disc or however much damage is there, whether we're calling it arthritic, deterioration, degeneration, all the fancy words that we have to describe damage, that damage is thanks to all of the malfunctioning of the entire system, thanks to this underdeveloped set of jaws. So the sooner that you can grow the jaws and start to heal that whole thing, you'll be shocked at how well things start to heal. But I don't have a single example of a patient over the last 8 years treating TMD symptoms where they didn't have a full resolution of every symptom. So whatever their list was, all of it to full resolution. And I have treated the patient who was in the vertigo category that couldn't get out of bed without falling down. That patient lost their job, they lost their home, then of course, debilitation, laying in bed. That was a spiral out of control to the worst possible list of credentials you could have. And we treated that patient to full resolution, got her job back, got her life back in order. The whole entire thing went to full resolution. Jaw growth and development first, teeth second. And then next thing you know, you have no symptoms whatsoever from a totally debilitated life. So the idea is it would be equivalent to, well, just because if you find damage in the jaw joint, well, terrific. You have another list of symptoms of degeneration over time, thanks to underdeveloped jaws and poorly functioning masticatory system. It doesn't mean you don't treat the patient. It's the opposite. You get in there as soon as possible. In other words, if you walked up to someone and they had a gash in their arm and they were bleeding badly, you wouldn't look at it for a while. You wouldn't try to figure out, should I treat that? It's really bad. You can't make something worse when you start doing growth and development. Now, if you start fighting with the teeth only, you can make things worse. So it depends what direction you're treating in. The last thing you want to do when someone has deterioration and symptoms is treat the teeth only. That's a recipe for worse. You treat the growth and development of the maxilla, and then you treat the teeth second. Now you're solving. And no matter whether you got in there after a year of symptoms or 3 decades and you have that arthritic degenerative disease, whatever you want to call it, you can start to heal that process and you can still relieve all the symptoms. So the sooner you treat the patient appropriately, the better.
Right. Yeah, very well said. What about tinnitus? I see a lot of patients, adult patients with tinnitus, some children.
Yeah.
You see that a lot, and you see that the symptoms going away as you expand the jaws?
Yeah, that's another symptom on the list. That tinnitus, it shows up more often than not. It's in the list. I don't have a lot of patients who made it their number one. In other words, when you ask people, what's the thing bothers you the most? That doesn't end up being number one. It turns out it's rare that someone says, that's the only thing killing me. I need to get rid of that. But it's in the list of TMD symptoms. When you have the lower jaw jammed so far back and that condyle's back and then everything is messed up, you're going to have a pressure in an area that will give you, part of it is that ringing in the ear. And so the moment you deliver maxillary growth and development and you can start to free that system up, you can start to have a resolution of that. Don't forget, a lot of these people will have the tongue tie to release, and most of them will need myofunctional therapy, because if you have soft tissue dysfunction, you are swallowing incorrectly also. And when you're swallowing incorrectly, it does have an effect on the eustachian tube, fluid flow, and pressure. And so if you only do the jaw growth and development, which is amazing and makes a big difference, you might not have full resolution of every single symptom until you include Frenum revisions with myofunctional therapy. Frenum revision and myofunctional therapy go a long way to resolving the last little issues. And so that's what I would tell you. If you've done wonderful things and the patient's much better, but there's still a residual, revisit the Frenum, release with myofunctional therapy, and I think you'll be, pretty happy with how things start to then resolve themselves to the fullest extent.
Do you ever have your patients go through myofunctional therapy early on so that they're, or tongue release early on so that their tongue and their oral musculature can work on your behalf rather than perhaps working against you?
Yeah, there's really no bad time to do Frenum release and myofunctional therapy, but my preference is to grow the space first. And so there's only so much improvement you can get in tongue function when there's a limited now home for it. In other words, because of the soft tissue dysfunction, the tongue doesn't have a proper space. So now this tongue has a small chamber to work in, and now you're going to be teaching it how to behave properly, but how can it behave properly? It doesn't have the right chamber to work in. So it's going to be compensating anyway. So it doesn't mean it's wrong to start early. You will just be doing it for longer because you're going to need the myofunctional therapy after you have the full development of the jaws. I prefer to start the growth and development first. And then once I have a significant amount of growth and development, we're into the myofunctional therapist because that's second. And then Frenum releases after myofunctional therapy gives permission to do it, because any patient that's going to have a Frenum released, whether it's the lingual or the buccal or the labial, it doesn't matter where, you never do that without myofunctional therapy pre-treatment. So basically you're doing myofunctional therapy for a few weeks leading up. It's like preparing the tongue or the lips for the release, then the release, then myofunctional therapy after. So in my world, it's growth and development, get your Frenums and your myofunctional therapy going, and then we go to tooth coordination. In that sequence is good, but it's not wrong to do it first. You'll just be in the myofunctional therapy longer because you're going to need more after you grow the space.
How important is diet during your patient's treatment? Do you counsel them or recommend a specific diet? Obviously,
it's our weakest section. So part of the consultation is in the nutrition category, but it's last on my list. So foundation, teeth, breathing, all of the things that go into hygiene, there's a long list. Nutrition shows up last only because I'm not likely to have a big impact in changing, number one, a child's diet, or number two, an adult's diet. So just imagine how many adults have we inspired to give up carb and sugar? I can't. So just I'll throw it out there. I can't do it myself. So why am I going to tell patients don't eat carbs and sugars because they're bad for your teeth and the rest of you? And then, of course, a child. How many adults do you want to tell, hey, when you take your 4-year-old home, throw out all the apple squeezers and make sure your child, next time they want apple something, you give them an apple and tell them they have to eat an apple. How's that going to go at home? So I'm not in the business of converting a soft diet to a hard diet. I'm in the business of treating an underdeveloped foundation, which is there now. And I have to go ahead and grow the jaws, get them caught up. Now, basically, we're exchanging that early soft diet with myofunctional therapy, because you do have to work the tongue, the lips, the cheeks, the head and neck. You got to work it with a physical therapist if you want to recover. So you can make it analogous to any type of surgery that requires PT to recover. In other words, let's say you get your knee or your hip replaced, and you got to go easy at first until you get to a point where, well, now your muscles have deteriorated a little bit. Because what if you went 2 or 3 weeks where you couldn't really work out and exercise? Now you got your new knee in there, you got your new hip in there. Now you're going to PT. Now we're going to start working that musculature. We're going to get it back to normal. Well, it's just like when you think about that child who has this weak and soft, so all this soft tissue dysfunction. You can put the expanders in and you can do wonderful things. But what if you don't address the underlying cause of the soft tissue dysfunction? So expansion appliances are wonderful. Brackets and wires with an appropriate technique after expanders can work. You can use clear aligners. You can do guidance appliances. But you really need in a child the myofunctional therapy if you want to keep everything that you're developed and then have it function properly in order to breathe well and swallow and chew and posture and speak. All of those things have to do with the PT of the jaws. That's what orofacial myofunctional therapy is. It's a necessity.
Yeah.
Dr. Stewart, you're doing such a good job asking questions. And this just lets me know that we need to do another town hall type of segment with this Dr. Moralia, where we just answer questions the whole time. So I'm going to set that up. But for now, we need to cut this short so we can go to our other meeting with the Stewart Center group. But we will answer your questions. We'll just have to do it another night because there's only so much we can do in one time. And you asked so many wonderful questions. So thank you for that. But I did want to let our audience know how they can contact you or learn more about the Stewart Center. So here's their contact information because we are in the same mindset, the same philosophy. So please check out their resources. I know Kathy is wonderful, and I heard you're very good, Dr. Stewart, at getting back to people as well. So please feel free, everyone, to reach out. We do have upcoming courses. I'm going to send all that information out to you guys. I think you know by now, most of our followers, you know we have a mini residency. A lot of these questions of how to do this, how can I incorporate, how does my hygienist talk about that? That's all really covered in our mini residency. That's why we created these courses, because there's no shortcut. You have to spend time to teach, and that's why we have these courses. So our next one, we have a couple of spots open for both the pedo and the adult in January, but those are filling up. So if you're interested in starting the new year, becoming an airway dentist, we look forward to hosting you then. We love our myofunctional therapy course. Dr. Moralia highly believes, and I know Dr. Boyd's also on the call, you have to have myofunctional therapy to have a successful case. In fact, that's the superpower. So we created a course specifically to teach hygienists how to integrate myofunctional therapy in the dental practice. So check that out. Dr. Boyd, I know you're on. We love you. We're so glad you're on board with faculty, and we're so excited to have a live course. Fingers crossed. I'm staying positive, not that kind of positive, but April 1st and 2nd in Hollywood, Florida. Learn more about that. You do need to take the mini residency as a prerequisite. And then we have our advanced mini residency. So we can talk all about that. Feel free to reach out to me. I'm available all the time to set up a call. We have saved the dates for other live events, the Dental Festival in Nashville. Nashville's a great town. This is a great team building event. These courses are designed to bring your team members. Airway Health Solutions is doing it July 8th. And then our sister company, Clear Align University, is holding a conference July 9th. Dr. Boyd and Dr. Moralia, Brittany and Carice and myself will all be presenting. And save the date, because I think we announced this last year, but it's official. We're going to have our first Airway Health Solutions Airway Palooza. It's live December 1st through the 3rd in Savannah, Georgia. We're going to have various experts in the airway field presenting. It's going to be really a great time and a lot of learning. There's also a golf outing attached to that for those golfers. We need more green dots. I saw some people in the chat saying today, oh my gosh, everyone needs to be expanded. I have so many people reaching out to me on a daily basis. Where can I find an airway dentist? Where can I find an airway dentist? Especially in the middle of the country, folks. I don't know if anyone is listening from there, but we need to fill in and connect some of these dots. So in order to become an airway dentist, it's simple. It's not complicated. Just take our online mini residency course with Dr. Ben Moralia. He has such a great teaching technique. You'll be on your way. And then we have support. So we have our Facebook Airway Dentist, a private Facebook, which we will be live streaming the town hall in just a moment for all our alumni. So join us there for part 2 of this presentation. But it's a great community, and you'll learn a lot from each other and our special quarterly guests. So I think that's a wrap. I really thank you. Let me just stop this, up the share, so we can see. Okay, well, thank you, everyone. We had a great participation. I hope everyone stays safe and healthy. And for the alumni, the Stewart alumni, come join us over on the other Zoom link in our town hall meeting for some more Q&A. Thank you, everyone. Thank you, Dr. Moralia. Thank you, Dr. Stewart. And we'll see the Stewart Center next link. Good night, everybody.
Good night.
See you in the next one.